Okay. How do you say this one? Next slide. It's right click. Just not going.
We are able to see.
Yeah. Next one, I just go to the paper start with them. Then again, later, the box, like the box. Okay. So, what is that box? Ah, that thing. Okay, that will be this one. Go back to this one. Yeah, Ramakrishna. Yeah, okay, fine. Okay. So the first candidate, please. Sorry.
Pawan Kadam.
Yes, sir. Yes, sir.
Yeah.
Dr. Pawan here, sir. Yes, sir. So it's Mr. Ramakrishnan, or 59-year-old male, resident of Coimbatore, is known case of ulcerative colitis since 1999, on follow-up in PhD since 2004. Currently on azathioprine and mesacol. Currently in clinical remission. Surveillance colonoscopy.
Yeah, okay. So he is a patient from 1999. Actually, he was in Bombay in 1999. And until 2004, he was in Bombay. He was found to have ulcerative colitis.
Awesome.
He was started on steroids.
Hmm.
And then he came out to Coimbatore. That has been followed with me now. And he had on and off some exacerbations. And right now, he is on azathioprine and
Mesacol.
Okay. So the question here is, how do you do a surveillance on him, and what do you want to look for in a surveillance in these patients?
What is surveillance colonoscopy?
What will be the surveillance? So what is the recommendation for surveillance? No, he is almost now 24 years into the disease.
Ulcerative colitis patients are usually at higher risk of developing colorectal carcinoma.
Just tell me the surveillance
Carcinomas.
because we need to go fast.
So colorectal carcinomas, we need to rule out for that surveillance. First, we'll do. Usually, we do if any symptom recurrence occurs. Otherwise, surveillance colonoscopy to rule out the development of colorectal carcinoma in such patients, sir.
That's all. Tell me the protocol, doctor. What is the protocol of surveillance in a patient with ulcerative colitis? He is now into 24th year of disease.
Is there any time period?
Is there any timeline when you do
timeline. Is there any timeline?
Do you do?
Is there any difference for universal colitis versus left-sided colitis? We are asking leading questions. When do you want to do? When the patient has come with blood and mucus, or we want to do it later? These are the three questions. When does the risk begin?
When does the risk of neoplasia begins? Number one. What is the protocol if you have pancolitis? What is the protocol if you have bronchitis? What do you, as sir asked, what is the protocol if you ask left-sided colitis? What's the timeline? When do you start looking for a surveillance program? How often you do surveillance? You do it once a year, or you do a biannual, or once in 3 years?
Sir, the risk of colorectal carcinoma usually increases after 10 years. 10 years after the diagnosis of the UC, sir.
If it's only left-sided colitis.
Is it the same or different?
That is different, sir.
What is it? How different? This is the way in which answer without giving any clue. Sometimes examiners will give a question such a way that you will get enough clues, but both of us are asking a question such a way that you don't get clues for your answer.
When I ask you, you need to tell how many years, since how many years, and what timeline will start annual colonoscopy. What is the pancolitis? What if it's left-sided colitis?
Can anyone else answer?
For left-sided colitis, 8 years of 15 years after the onset of diagnosis, and every yearly we have to do colonoscopy. For pancolitis, 8 years after the diagnosis, every yearly colonoscopy to look for dysplasia and malignancy.
Proctitis? We have ulcerative proctosigmoiditis.
Proctosigmoiditis, 15 years after the diagnosis, every yearly colonoscopy.
Okay. Now, so currently in clinical remission on azathioprine mescaline, and we did so you underwent an annual colonoscopic surveillance. So, Dr. Pavan, what is it you want
Yes,
to
sir.
see in a annual in a surveillance colonoscopy in these patients? What are you focusing on?
The condition of the mucosa, if any lesion I can found.
No, what lesion? How
Vascularity.
will you find out? Will you find the lesion just like you see a de novo colonoscopy, or what are the lesions?
Find multiple pseudopolyps extended throughout the colon.
So
These
you'll
are
find
lesions.
multiple pseudopolyps. Then how do you detect any suspicious area?
What are the things which will lead, you should have greater suspicion. What are the lesions which will lead to think that this is a likely, potentially malignant lesion? When you do a surveillance colonoscopy.
More like ulceroproliferative lesions, sir, rather than the pseudopolyp.
Do you think the classic ulceroproliferative lesions in
Lesions are seen in patients with
ulcerative
UC.
colitis? What is the essential difference between the malignancy seen in ulcerative colitis versus de
Versus a
novo
de novo
colon
malignancy.
cancer? What's the essential difference?
Anybody else, please?
Say, okay, nowadays these are flat and infiltrative lesions. Very difficult to see by an ordinary endoscopy. Flat and infiltrative lesion. Second, they may not have additional symptoms. Most of the patients with ulcerative colitis have altered bowel habits, some colonic symptoms. These patients also may come with the bleeding, and you may think it's the same exacerbation of ulcerative colitis, and you may miss it completely. Okay. Then there are certain larger polypoidal lesions. Which are okay, and strictures. If you have stricture, you must be very careful. Stricture and large lesion. Flat and infiltrative lesions are not that easy to find, but I think with the chroma endoscopy or NBA, people can detect it.
With chroma endoscopy or an NBI, you need to do.
Yeah.
But as Sir said, you will not get any additional sinister symptoms. You may have to pick it up on things. You don't see a big large polypoid lesions. You may have to more often. Sometimes you may get it on the right side, and you need to what is called as DAM lesions. What are DAM lesions?
DALM, DAM.
DALM. Dysplasia associated mucosal lesions. These are things we need to look into this. So this was a colonoscopy. So you can see the cecum is absolutely normal. The right colon was looking very, was also
Hello.
looking.
The dysplasia associated mass. Hello.
Okay,
Yeah,
okay. We are
able to hear you, yeah.
Who is
The
talking? We
dysplasia.
are not able to see you.
Hello. Hello.
Okay, Pavan, you are back. Okay.
So it is.
Hello, sir. Can you?
Yeah, we can hear you. Go ahead, doctor.
Dysplasia associated mass lesion, sir.
Okay,
Yeah.
we have finished that.
So
Suppose
that
you
is
don't
now-
find any lesion, will you take the colonoscope back or will you do anything? No lesions found. So we are happy that there is no large polypoidal lesion, no stricture, no flat or infiltrative lesion on chroma endoscopy or NBA. Nothing is seen. What will you do?
What will you do?
So considering the duration of the disease, I will take the biopsy anyway, sir.
How do you take biopsies? What is the recommendation of how many biopsies at what intervals you take in a colonoscopy biopsies? You have to take biopsies on every 10 centimeters. 10 centimeters, you need to take biopsies in the segment.
You may end up with 15 different bottles.
Yeah. You'll have to take at every 10 centimeters segmental colonic biopsies. Okay?
Sir.
Okay.
There's one special precaution you have to take it when you take biopsy for dysplasia. What is that?
So what do you see here now? Once we reach the left colon, some 25 centimeters something, can you describe this?
Sir,
What do you see
mucosa
here?
looks Sir, on the image on right upper side, it's mucosa looks pale with multiple pseudopolyps are there, sir.
That's okay. What do you see here?
That looks like looks like a
What do you see?
polypodal lesion.
So there
On
is
the
a
right side, sir. Yeah, there is a
polypoidal lesion here,
polypodal lesion. Yes, sir.
occurring here,
Uh,
and above that, you have another polypoidal lesion, which is looking like a, what do you call this? Such a big lesion. What is LST? Lateral spreading tube. So you can see here, there is one ulcerated lesion. This looks very suspicious. Okay.
Awesome.
So apart from taking these biopsies, this looks like very suspicious. He is 24th year into ulcerative colitis, completely asymptomatic. ES hemoglobin 15, ESR 2 millimeters, CRP 0.9, albumin 4.8. Absolutely asymptomatic, and that's what you see. So you got to be very careful when you see these lesions. Okay.
Awesome.
So you have taken segmental biopsies. Important when you see this lesion, how is the surrounding mucosa? Is it very ulcerated, or does it have any active colitis here? You don't see much of active colitis here.
No, sir. It looks quite edematous, though.
No, this.
Why should you
does not
Loss of
bother
fluid.
about active colitis? Anyway, that will be ulcerative colitis and inflammation. Why are you so bothered about active colitis?
Colitis
When you
around
look
that
for,
lesion. Around
when
that
you look for these lesions.
Oh.
Okay, to cut it short, I will tell you. In the absence of
Will you
any
read?
visible lesion, we actually look for microscopic evidence of significant dysplasia. One should not look for evidence of dysplasia when active inflammation is present, because the
Awesome.
findings in acute active inflammation may mimic those of severe dysplasia, and you may unnecessarily subject to further evaluation and sometimes even surgery unnecessarily. So to avoid that, you should always do surveillance when the patient is in remission,
Remission.
Awesome.
and avoid areas which look actively inflamed. If at all, you
When
find
there is acne, there can be inflammatory associated degenerative atypia or some dysplasia. So you need to look at that area. So you take a biopsy of this. So look at this lesion. Okay, that's the same lesion which is the other end. You will find that there is a lesion, new lesion which we have not seen. He has undergone a colonoscopy in 2022, but this is a lesion which we saw this time. Okay.
Awesome.
So we took biopsies. So our thing was, can you go through this, please?
Seen up to terminal ileum, and IC wall are normal right colon. UCS is 6, starting at 45 centimeter from anal verge, at 30 centimeters, large 2 centimeter flat lateral spreading adenomatous polyp adjacent to adjacent to area of moderate activity noted. Sir. And 25 centimeter of from anal verge, deep excavating ulcer along with few pseudopolyps noted, suspicious lesion.
And there is a preserved mucosa from rectum to 20 centimeters. So this is
20
a
centimeter.
very suspicious lesion. And then biopsy from that lesion
Right.
5 centimeters.
Right colon is chronic inflammation. Then descending colon, chronic inflammation, focal low-grade dysplasia. And where the lesion starts, it shows fibrosis, tissue eosinophilia, degenerative changes. And biopsy from anal verge polyp shows adenomatous polyp with low-grade dysplasia. And anal verge ulcer shows adenocarcinoma with signet ring cell component.
Oh.
It's signet ring cell carcinoma, sir.
Yeah. So we have got a malignancy. Now, how do you proceed on? How do you work? What is your management principles in this patient? So he has got 25 centimeters an excavating ulcer. There's a lateral spreading tumor which was adenomatous polyp, and this shows adenocarcinoma.
where is this ulcer located?
At 25 centimeters from the anal verge.
Okay.
We have reported that from anal canal to the rectum, 20 centimeters, it is completely mucosa is
Perfectly
free.
normal, yeah. This is a signal cell carcinoma, Pavan. What will you do?
So what do you do next?
It's a disease of the sigmoid colon.
You got a sigmoid colon disease now. You got a sigmoid colon malignancy.
Yes, sir. I will first do the radiology to rule out the mates regarding this lymph node involvements and all.
We
To rule out the
did a,
mates.
we did
You will
a
do staging.
See here, we
Staging.
just picked it up like that. So we do a staging. So what do you do here? At 25 centimeters, what staging? How do you imagine?
We need to take CCT abdomen along with the HRCT thorax to see the extent of the disease, lymph node involvements, and the metastasis, sir.
Or you want to do MRI?
Loco-regional.
Or you want to do an MRI of the
For-
abdominal pelvis?
For the pelvic region, MRI would have been.
But we are not dealing with
Look at the
rectum, no?
lesion, doctor. The lesion is at 25 centimeters. It is above the peritoneal deflection. So I think CT abdomen. You should tell us why you have done a CT and not an MRI. Here the lesion is 25 centimeters. So you do a CT abdomen and HRCT lump because it's above the peritoneal deflection. If it is from 10 centimeters or 15 centimeters something, it is below the peritoneal deflection. Then you do an MRI with
MRI. Okay.
What is the reason, Kadam? Why MRI is done for C rectum? Okay, the mesorectal fascia is better evaluated, better seen on an MRI compared to CT. We want to assess whether the infiltration of the mesorectum also.
Okay, sir.
So you want to do CT abdomen, CT thorax.
Huh.
So this is what you want. So what are the specific investigations you will do on this patient? So
One
you
is
said
the
CT abdomen,
okay.
HRCT. In the CT abdomen, we didn't even see any involvement of the serose. Mild thickening at the sigmoid colon, but there was no involvement of the serosa. There were no nodes. Liver looked perfect, and HRCT is normal.
No nodal involvement, sir.
No nodal involvement. See, it shows only a mild thickening of the mucosa, submucosa in the thickening. There is no evidence of involvement of the serosa. No involvement of any. There are no nodes. There are no peritoneal deposits. Liver looked normal, and HRCT thorax was normal. Next.
So what surgery you will recommend?
What surgery you will do in this patient?
Sir, unlike normal C rectum, I would like to go
Doctor,
for the
yes,
extensive resection.
Sigmoid colon.
Doctor, here is a
Extensive resection.
What do you want to do in this patient? Patient, look at this. Patient has got ulcerative pancolitis. Incidentally picked up excavating ulcer, adenocarcinoma. He is a known IBD for 24 years. 25 centimeters, there is a lesion, which is not going beyond the serosa. So it is Q1. What do you want to do in this patient? Tell me the procedure you want to do in this patient. Fast, doctor, because I got 3 more cases to see.
Ideally, submucosal dissection would have been.
The patient has got ulcerative colitis.
Can
Left
anyone
hemicolectomy, sir.
Red cell adenocarcinoma.
Left
Pawan said
hemicolectomy.
something. What is it?
Left hemicolectomy. We can.
Patient has got ulcerative colitis. What do you do in a malignancy and ulcerative colitis? Will you do a left hemicolectomy?
Okay, essentially,
We can opt for total
is there a difference in the type of surgery between the malignancy and ulcerative colitis?
Colitis and
yes, sir. We opt for the more extensive resection of the colon, sir.
So how much of
Total
It's a question of option, doctor. You need to do a
total
colectomy? That's the
total
answer.
colectomy. Total colectomy, yes, sir.
total colectomy. And what do you do with the rectum?
Pardon, sir?
What is the procedures?
Rectum.
What are the procedures? What are the procedures you do in this situation? One is total proctocolectomy. One
Yes,
is
sir.
you can do a subtotal colectomy and leave the rectum. Okay.
Total proctocolectomy.
Which is a better surgery, total colectomy?
Which is a better
or
surgery in
subtotal
this
colectomy?
patient?
Total proctocolectomy, sir.
Okay, but how will you
In
construct the
terms
area?
of prevention of malignancy, that is good. But in terms of continence and bowel evacuation, the
Then
subtotal will be better.
subtotal with the, yes, sir.
Okay, then you have the risk
rectal
of
sparing.
malignancy occurring in the rectum, no?
Yes, sir.
Anybody else, doctor? Anybody else can tell me clearly what do you do?
Rajendra,
Yes, sir. Total proctocolectomy with ileal pouch channel anastomosis.
What is the problem with ileoanal pouch?
Pouchitis,
No, this patient was passing stool once per day. How you do an ileoanal pouch? What will happen?
one is chances of leak anastomotically.
You do an ileoanal pouch. What when somebody has got pouchitis, he'll pass 30 times per day.
Yes.
So that is one problem. And what is the incidence of pouchitis in patients? 30% is incidence of pouchitis. So in this patient, you have an option of doing subtotal colectomy, and you can leave a part of rectum and do, because we discussed with him, he said he cannot tolerate that so many times. So you need to take the idea. But here we looked at showed that 20 centimeters of rectum was completely normal, but it did not show any dysplasia. So here you have two options. Either you do a total proctocolectomy in ileoanal pouch, or you do a subtotal proctocolectomy and leave out a rectal stump. Okay? And later ileorectal anastomosis. Right.
is that the end of the story? That means
the end of the
his
story?
rectum is out.
Look at the CT
His
abdomen.
colon is out. Therefore, will you stop treatment and will you be happy forever?
So the CT
sir, we need
abdomen showed only minimal surgical wall thickening, no extension via serosa, no evidence of distant metastasis. So once you do a proctocolectomy and leave the rectum, are you happy to leave the rectum or you're not happy to leave it? How will you treat his ulcerative colitis? Supposing you are opted for ileorectal anastomosis, how much of rectum you will generally leave? If it's feasible, leave about 10 centimeters of rectum on this
10
thing.
centimeters.
So then, Dr. Pawan, how will you follow him? How will you treat this ulcerative proctitis here? Once if you do a surgery on him,
Pardon, sir?
he'll have some proctitis. You are leaving him.
Yes, sir.
So what we did here is he did not opt for a ileoanal pouch when we explained the cause of pouchitis. So we went the laparoscopy total with the ileorectal anastomosis. 10 centimeter rectum was left. Now, how will you treat his ulcerative colitis and how will you do a surveillance?
So we'll treat the ulcerative colitis now with the regional therapy and
No, he doesn't. He's got
surveillance.
only one rectal stump available. Azathioprine, mesocol, everything. So all swollen was out, and there's only rectal stump. So how do you follow up this rectal stump? Should we follow it up? Number one.
Yes, sir. There are chances of malignancy in the spared region. Yes, sir.
So you need to do. What will you do? How will you look for that?
We need routine sigmoidoscopy, sir, to rule out the and regional therapy too.
Sigmoidoscopy every 6 months for 2 years, and then once a year. Then, how do you treat his? Suppose his ulcerative colitis. So he has got a rectal stump. How do you treat it?
Only regional therapy will have been sufficient, sir.
What will you give?
What will you give? What regional therapy?
Because it is better, Pawan, to answer the answer straight away. Because otherwise, examiner will have to ask one more question. You say regional therapy. We'll have to ask.
You tell that you use suppository or what will you?
Suppository will be enough, sir, as only 10
Suppository
centimeters.
of what?
If we ask these questions, you just tell what.
Mesacol suppository.
So we have just put him on
Don't say mesacol because
and we plan to
mesalamine.
5-aminosalicylate suppositories.
Yes, sir.
Can read this biopsy.
These are
What do you see here?
multiple. These are multiple glands, sir. Rec-
You can see hyperchromatic nuclei in all these glands. Okay,
yes, sir. Oh, sir.
there's a bit of fibrosis here and multiple, all the nuclei are shifted here. So this was actually an adenocarcinoma of the colon.
Colon.
Okay, so this is the biopsy from the whole colon which they taken. You can see most of the time the nuclei are all pushed to one side. It's a hyperchromatic nuclei and you can see everything. So it was an adenocarcinoma of the thing. So this is a patient with inflammatory bowel disease.
Oh, sir.
It was well differentiated adenocarcinoma. Okay.
Yes, sir.
Does he require chemotherapy?
No, sir. It can worsen the disease per se, and there is no nodal involvement or regional spread.
So discharge medication, should you continue azathioprine?
No need, sir.
No need azathioprine. So you can,
Yes, sir.
you need to put them on a local therapy with the
Local therapy.
and do a
Yes, sir.
protocol.
Yes, sir.
So this is a basically, so take home basis, how you should know, reading objectives are, what are the guidelines to do a surveillance protocol, how do you diagnose lesions. Look at these lesions, they are very, very subtle. And what are the treatment
Yes, sir.
managements? You cannot go and tell I'll do ESD and do left hemicolectomy on this patient. He needs a total proctocolectomy, proctomy ileoanal pouch, or you can do a subtotal colectomy with a proper control of the proctitis of the stump, the rectal stump, as well as you should need to do with a patient, and you should also have a very, very robust surveillance protocol, because what is the chances of malignancy in that particular leg stump? Please read up. What will be the percentage of things you can transform? Okay.
Awesome. Okay, sir.
LPK, the lesion was somewhere around the anal verge, you said, no?
No.
No.
It's in the 25 centimeters from the rectum. That this one they said mild thickening of the anal canal in the CT, but it's from 25 centimeters from the this thing, and up to rectum to 20 centimeters was normal. Biopsies were normal. So 25 centimeters, we had a small puckered lesion followed by a lateral spreading tumor. And that one came out as a well differentiated adenocarcinoma.
Just want to know clarification. When would you recommend an ESD?
Recommended?
ESD. Dissection, no? Dissection.
Submucosal dissection.
They have these lateral spreading tumors. Lateral spreading tumors.
A lateral spreading tumor was there. Probably we can do it, but if this patient had an adenocarcinoma, so we went through it. And the
I think,
study showed as an
the-
adenomatous polyp.
Basically, these people are likely to have more tumors in future as we wait. So if you don't remove the colon, we will end up with too many ESDs, because adenocarcinoma is likely to occur in multiple places as we move on. So better to have a total colectomy or proper colectomy. But technically, yes, it can be done. But there may be a problem compared to de novo tumor, because there will be some degree of
So we don't know.
submucosal
Yeah,
changes.
there may be another tumor somewhere else. Okay, I think.
The earlier report was of pancolitis, or was it a case
Pancolitis.
of
The patient is a pancolitis. Yeah. You
The
can
colon
even see in
was-
the biopsy, the right
Yeah.
sided colon still showed inflammation and colitis.
inflammation? But did it show a distortion? Because it looked really near normal, no? It looked like a histological.
It's a very well
normal.
differentiated adenocarcinoma.
No, not the tumor, the right side colon.
Looks very normal. He's been on azathioprine for a thing. He's doing very well. It's quite robust. Hemoglobin was doing. Actually, even I think Shobana madam also has seen him when he was in Bombay. Shobana madam.
Could this be azathioprine related tumor?
Madam?
Azathioprine induced tumor.
Lymphomas, no? Azathioprine
They
induced
are
tumors are
mostly
generally
lymphomas and very malignancy, but
lymphomas.
we have not seen. He was on azathioprine right from the beginning. He was only on 50 milligrams of azathioprine. So this case is just to highlight how do we do a surveillance, what do we do, and then do the malignancy. Okay,
Yes, sir.
so we'll go to the second case.
How to differentiate inflammatory polyp from malignant polyp? Venkat, there's a question. How to differentiate inflammatory polyp from malignant polyp?
If there is a
I think
polyp
with the
as it is, I
NPA,
think
nowadays
we
it is
need to do a
good.
polypectomy and then send it across. I think if there's a polyp. That is also, I think I just,
Inflammatory polyp is a pseudopolyp, no, it's a pseudopolyp.
Yeah, most of these are pseudo polyps, but I think with the NBA, one can have a look at it.
we can
And
do a thing, but
probably
I think it's better to do a biopsy on this. I would
yeah, always better to do biopsy if it is larger ones.
large one. Can we go to this case, please? Are you able to see, sir, this case?
Yeah, Mohan Priya. We're discussing next. So thank you, Pawan.
I'll-
Next, Namit Reddy. Okay.
Yes, sir. I'm Namit,
Thank
sir.
you,
I'm here, sir. Mr. XYZ, age 21 years, female, presented with chief complaints of vomiting since 8 months, abdominal pain since 8 months, and fever since 1 month.
So this patient had, he has come to us from elsewhere, and then she had vomiting since 8 months, abdominal pain since 8 months, and she had fever for 1 month.
History of presenting complaints. Patient was normal till 8 months back, after which she developed abdominal pain, which was insidious in onset, intermittent, gradually progressive, right iliac fossa in location, which was colicky in type, non-radiating, no aggravating and relieving factors, no abdominal distension.
So she had fever, low grade with evening rise associated with chills, and she had 20 kg weight loss over 6 months. Okay.
Yes, sir.
This is what I think of this thing. Let's go to this.
Treatment history. She was evaluated elsewhere and on imaging was found to have possible intestinal tuberculosis, for which she was started on ATT. Following initiation of ATT, symptoms persisted, hence she discontinued the medications after 2 weeks of usage.
So initially that they brought a CT which showed some ileocecal thickening, and there was also a mild ascites or something. So she was started on ATT, but she initially took for 2 weeks, stopped it, and again she went to another doctor, and she took ATT for nearly about 3 to 4 months. But absolutely there was no improvement. That's what she says. Okay, that's what it is.
Can I ask a question? What are the situation in which the patient will continue to be symptomatic despite the correct diagnosis of tuberculosis, and you have put the patient on ATT? This sort of situation, after 2 weeks she discontinued. That means she was not feeling well. What are the situations when the patients feel that they are worse after taking ATT? Scenarios. Okay, I will answer. Suppose there's an intestinal obstruction, that part will not be tackled by the ATT. So the patient will continue to be symptomatic and they will think that the vomiting, pain, etc. is not relieved, and therefore they may attempt to stop it. Second one is development of drug-induced liver disease. The vomiting will be one of the important manifestations to begin with. So they may also think that this is part of the original illness and someone may stop it, or we will have to stop it this time. Okay, kindly proceed.
So she was actually registered in the government setup, and she continued to take ATT for 3 to 4 months. And she did not improve at all. She said the pain was still there.
Can I ask a
Yeah,
question?
Shobna ma'am.
So I'm here. How do you explain the vomiting, doctor, in this patient?
Jayanti ma'am.
Watery vomiting. How do you explain the vomiting in this patient with the pain in the right iliac fossa?
No,
Because of the, because of the distension, like
No, what are the causes of vomiting? patient who's got a right iliac fossa pain.
We have already said it is
Already I've told
ileocecal
us, they've told us, sir has already told.
Just go to the previous slide, please.
on vomiting.
The vomiting slide, yeah. Go back. Go back, go back, go back, go back. Now just describe this vomiting.
Vomitings were watery, non-bilious, non-bloodstained, aggravated after the food intake.
So what does it mean? What does it indicate?
It could mean like it is above the biliary, so
Above the?
it's not involving the duodenum.
So
If it is
two
non-bilious.
pathologies, no? One, there's a pathology in the proximal part of the duodenum, proximal to ampulla, and there's one other pathology in the right iliac fossa.
Right iliac fossa.
Yes,
Right?
yes, ma'am.
So there's a dual pathology, right?
Ma'am.
How do you explain, doctor? You have to say, no, the vomiting is there. So what's your diagnosis after the history taking?
In view of the, also as she gives the history of fever along with weight loss, then and evening rise of temperature was seen. So I would like to think of
Right iliac fossa
tuberculosis.
pain, fever for 1 month, low grade evening rise, loss of appetite, weight loss of 20 kilos, right iliac fossa in a 21-year-old lady.
Is it likely that
First-
this is tuberculosis or do you consider something else?
I would consider tuberculosis as the first DD, sir, first differential. Then
Okay.
But you know, you haven't still answered the causes of vomiting in this patient. This is Shobna Bhatia.
yes, ma'am.
You said it is non-bilious, non-blood stained. That doesn't necessarily mean that it is the cause of the vomiting is proximal to the duodenum. The pylorus is usually tightly closed. And it is only when a patient has vomited out all the gastric contents that the duodenal contents start coming up into the stomach. So bile doesn't come out just within the first or second vomit, unless it's already contaminated the gastric content. So you got to be careful about this. So what do you think usually in a patient who's had this fever and weight loss is the usual cause of vomiting in such a case? Just name a few, 3 or 4 things.
Like any gastric ulcers or like because of the anorexia.
Anorexia is not associated with vomiting.
Gastric ulcer, huh?
And why gastric ulcer?
Watery vomiting. What's it? So in other words, what we want to tell you is that when there's a pain in the right iliac fossa, where do you think is a predominant lesion? Is it in the terminal, that portion, or you think there are dual lesions? If there are dual lesions, the patient is unlikely to get a pain in the right iliac fossa because the person is vomiting. So there'll be no
Yes, ma'am.
related pain. So the distal pathology will not be obvious, it will be obscure. So you
Yes,
have to be
ma'am.
very careful in that history taking at this level, okay? Or does
Yes,
the
ma'am.
patient have dual pathology? Because you cannot get pain in the right iliac fossa and also have vomiting and the pathology looks like. So we need more information on that vomiting. Does it contain stale food? Is it after a meal? Is it overnight fasting that the patient continues to vomit? In which case the distal pathology will be masked.
Yes, ma'am.
But
Any
the
strict,
weight loss, loss of appetite, it may be all related to the proximal pathology, nothing to do with the distal pathology. So do you think it is gastric aortic obstruction, tuberculosis, cicatrizing lesion at the pylorus, anteropyloric region?
any stricture you can call like
Okay.
So it's very important.
because of
Okay, anyway, it's very important to have a history of nausea in this case, because the patient has had fever for very long and they're having nausea. They just might bring out whatever they eat, and it may not relate it to this.
yes, ma'am.
Okay,
Dr.
kindly
LBK,
proceed.
Dr. LBK, do we have any information on vomiting that I'm still harping on that? Do we have any further
Initially,
information on
yeah,
that?
she had this non-bilious vomiting and all. And it was getting aggravated good. Then she was started on ATT.
So
Then
Dr. Reddy, I just want
2
to
weeks
know,
later-
in a patient with distal small bowel obstruction, tell us few things about the vomiting. Just describe the vomiting in a patient with distal small bowel pathology.
distal small bowel, like
Is this vomiting and that of a distal small bowel obstruction?
no, sir.
Why it is so? Why do you say no?
Because when it involves the distal small bowel, we'll have bilious vomiting.
Okay, one is bilious. Anything
Bilious
more
vom-
important than bilious?
The periumbilical pain.
Okay, regarding vomiting, we are concentrating on the vomiting.
Okay. Vomiting.
So what I would suggest is, when the focus is towards right levels, and just come down on the vomiting history. Don't make it as a major presentation in this patient. You'll not be able to explain it. So if the patient has ball rolling movements, has got abdominal distension and vomiting, that
Distension.
gives you a feature of a partial small bowel obstruction. But in its absence, with the patient just a pain in the right leg fossa with some vomiting, which may not, I would really go slow. It would be a soft symptom for me, and I'll not think too much about it, because we already gotten information based on investigation. Patient has had an ATT, so I'll not bring in that
Yes.
vomiting bit at all in this patient. Okay.
Yes, sir.
Okay, move on now.
Okay, okay.
Move on.
On examination, the
No,
general examination.
On examination, now what's the final diagnosis? Patient has come to Dr. LVK, ATT, no response.
ATT for 4 months and
Current
then
BMI,
no response. She still has pain. She has still vomiting. She vomits, I think. She still has a periumbilical pain. So we didn't find anything much. So how do you go about it here? 2 or 3 months of ATT. She says the fever has settled, but still there is a persistent pain, vomiting. She has not really gained weight.
What are your differentials apart from tuberculosis?
Is there any stricture, ma'am? Stricture.
No, if it is tuberculosis, why is she not responding?
I think someone else must just take over because he's not able
Why
to.
is she
Initially
not
by 2
responding?
months,
Any
there
drug-
is some response, and now it is 4 months, no? The
Now she has
patient
come
would
to you
have
because
responded.
she's taken 3 to 4 months of ATT.
Drug.
Yeah, some
drug
degree of
resist-
improvement we would have expected in terms of symptoms, in terms of weight gain, all those things. Nothing is happening. So,
drug resistance. And
drug resistant. How often you get a drug
Yeah,
resistant?
correct.
Was she having open pulmonary tuberculosis earlier and she was treated multiple times with ATT? Is that a situation? No.
no, sir.
Important
Otherwise,
thing is
de novo drug resistant GI tuberculosis
uncommon.
is extremely rare.
you know
Because
what?
most
This is
of these
especially
people
in
would
GI
have got
tuberculosis.
infected during their childhood, and it is actually reactivation of the tuberculosis which is happening. The tubercle bacilli which resides in the macrophages will get reactivated and produce the disease. So it is not a recently acquired infection. Okay,
Yes, sir.
most of the cases.
De novo resistance for in GI tuberculosis is very, very uncommon, actually. Drug resistance is very,
Yes, sir.
unless you think.
Okay, have
So
you
if-
considered that there is a lesion in the bowel which is kind of, partially fibrotic, partially
Yeah,
edematous?
stricture.
So there may be a stricture there which had predominant fibrosis. Plus, remember that tuberculosis heals with fibrosis. So when it
Yes,
starts healing, sometimes these strictures actually become more tight. And the GI symptoms don't improve, but the systemic symptoms should improve. That means the appetite, maybe the weight, and the fever go away. Appetite improves, fever goes away.
Yeah. I think,
Yes,
Shobana ma'am, please
Yes.
highlight that once again, because those of us, we know what you told, but for the benefit of others, how they present with a stricture or the stricture which evolves while on treatment
Yes.
versus a person who doesn't respond at all.
So what I'm saying is that tuberculosis inflammation has two parts. One is the inflammation, which is associated with a small amount of swelling. And the second part is the fibrosis. Now, tuberculosis, like Crohn's, can be a transmural disease. Now, what happens is once you start the ATT, the inflammation subsides and the tuberculosis heals by fibrosis. So therefore, a new onset fibrosis starts. At this point, the patient's systemic symptoms improve, appetite may improve, fever goes away, but the GI symptoms may not improve and can actually get worse because the stricture is now becoming more fibrotic and more resistant. So therefore, this is what we have to keep in mind. And this problem starts about 6 to 8 weeks after start of therapy.
They may also gain weight, ma'am, no?
They may or may not
They may
gain
or may
weight.
not get weight.
Depends on if they are vomiting. If they're continuously vomiting, have a subacute obstruction, they may avoid food and may not gain weight.
So this is what happened to her. She did not, she said she took ATT for 4 months and then she fever came down, but her pain subsided. She did not really put on weight. And then she switched on to another hospital, another place where they investigated her.
The blood investigations, like the hemoglobin is 9.1, ESR of 100 mm, CRP was positive. The peripheral smear showed normocytic normochromic anemia with relative lymphocytosis and mild thrombocytosis.
The special smear
The
gives
The
you
ESR is
how much?
100, CRP is
Yes, sir.
4 positive.
Yes, sir.
Yeah.
Total bilirubin is 0.4 with direct 0.3.
I think this is,
Indirect point,
I think she
yeah.
came to us actually. Yeah. Okay.
Total
Tell only
protein
the
is
abnormal
4.
ones.
The total protein is 4.5 with albumin by globulin 2.1 by 2.4. Virology is negative. GGT is 11.
So what does it show?
It shows hypoalbuminemia, sir, with AG reversal is there.
These are all
The complete urine examination, no evidence of albumin, RBC, and WBC. The stool return showed no ORCs, no parasites. The fecal calprotectin is 207, which is elevated. Chest X-ray, no evidence of any tuberculosis, consolidation, or lymphadenopathy. The ManQ test was negative.
what do you see here?
Can you see it?
Some 5.
The first one? Yeah. So which part of the intestine is this? Lower, upper? Namit, are you there?
Yes, sir. Yes, sir. I'm there, sir. I'm there. This
Okay.
is the-
Which part of the intestine is this? Which part of the abdomen is this?
This is the upper, sir.
This is upper. In the upper, what are things you should look for? Liver, stomach,
This is what
spleen,
here.
kidneys,
Lower.
etc. Nothing is there, no?
Liver, nothing
Cecum,
is
sir. I mean, lower.
Yeah.
Okay.
It's
Cecum.
mostly in the distal ileocecal region. You can see a very, very tight stricture in this patient. Okay.
Second
Yes,
picture
sir.
actually shows the marked thickening, no?
It shows a moderate thickening, and you can see that there is a
Terminal aerial structure.
post-stenotic, lot of dilatation. Okay, you can see all the small dilated bowel loops.
Yes, sir. CT enterography showed circumferential enhancing wall thickening, noted in the distalmost loops of the terminal ileum, ileocecal junction, cecum, appendix, and the proximal ascending colon. There is associated inflammatory changes in fat stranding noted in the RIF, prominent vasa recta noted in the cecal region. There is luminal narrowing noted in the ileum and cecum, with dilatation of the proximal ileal and the jejunal loops. Multiple enlarged mesenteric lymph nodes noted in the right iliac fossa and the pericolic region, largest measuring around 12 into 10 mm in the right iliac fossa.
What do you think this, based on this, what do you think she has? Still be tuberculosis, 3 to 4 months of ATT.
It could be The terminal ileal stricture,
No, there is already a terminal
Oh,
ileal
yes.
stricture that I showed you, ileocecal junction is there. And then the proximal ascending colon also. There's a lot.
or it's Crohn's, which was wrongly diagnosed as tuberculosis.
It could still be, I think, Dr. Jayanti madam or Varghese or Shobana madam. This could still be tuberculosis because it's only very, very localized, no, on the right side. And you have only the ileocecal prominent vasa recta and some enlarged mesenteric nodes are seen. And there's some fat stranding. I agree that fat stranding does not usually occur in patients with tuberculosis. That is what that you have the creeping fat index in radiology of this.
The disease of the ileocecal region with the classic.
Classically in the
thickening,
ascending
etc.
colon. So it could still
Oh,
be.
Yes,
so,
sir.
it can be tuberculosis, it can be Crohn's. If there are
Crohn's.
multiple
Can be
areas involved, we would have
tuberculosis or
definitely told it is Crohn's. But with this, with the failed anti-tubercular treatment, even after 4 months, there is not much of response. One may be tempted to think in terms of
Terms of
something else
Crohn's.
like Crohn's. Yeah, the
Crohn's.
lymph
So
nodes
what do you
are
do?
just above normal, 12 up to
12
10
into 10 millimeter.
Okay, 12 millimeter is just borderline. And if the lymph node does not show any necrosis or anything, we can't give much importance to it. Okay, if she had shown on necrosis
sir.
or calcification, we would have given importance to it. But the lymph nodes as such will not help us to make any other differential diagnosis at the moment.
Yes, sir.
So what do you do next?
What next?
What next you will do?
We can
You
do a
should not take this
colonoscopy.
much time in the examination to answer.
We don't have this much time.
You should
What do
be
you do
a funny
next?
to answer.
Colonoscopy
Next
to take the biopsy.
Okay.
Biopsy.
Describe this. This is
It
the.
is like some ulceration.
This is the hepatic flexure. This is the ileocecal.
Edematous ulcerated IC valve with superficial.
Hmm.
Like
Minimum,
pseudopolyp.
you have C and ulceronodular lesion. You have a. You're not able to move into the ileocecal region. Okay, because it's all strictured off there. And in the hepatic, you see some discrete ulcers.
Yes, sir.
So if you take biopsies, what are the things you will send for?
We'll send for gene experts, sir, initially.
Gene expert.
Pardon?
Gene expert. Gene expert. Gene expert.
Okay, then
How do you take the specimen for gene expert?
gene expert. And how many specimens you take?
What's the medium used for gene expert sending the
With-
specimen for gene expert?
Without formalin, we'll take
So
it.
one, will you just take it in a filter paper and send it as a dry one?
No, sir, in a sterile container, but without formalin.
How many you send? Minimum for gene expert. It should at least be 2 samples, okay?
Two. Yes, sir.
Okay. Gene expert was negative. And AFB, well,
Gene.
we always send automated AFB culture, gene expert and histopathology.
Yes, sir.
Biopsy. Can you read this? What do you see this?
What is the most striking thing?
This thing.
You look at the entire specimen and find out how much percentage of the field is affected by the lesion.
The fibrosis, like that.
Are you seeing fibrosis here? What do you find on the first one, the right lower part of the field?
Just.
They are dense inflammatory
Are there any
reaction. No?
there?
Dense
What else?
inflammatory reaction with the necrosis.
Yes, sir.
What do you see here?
Microscopic, the biopsy report, microscopic appearance. Studies showed the fragments of ileocecal junctional mucosa with fairly preserved crypt architecture. The lamina propria shows closely packaged glands, moderate lymphoplasmacytic infiltrate, eosinophils and patchy lymphoid aggregate with prominent germinal centers are noted. No evidence of granulomas are seen in the section studied. The specimen B, fragments of colonic mucosa with fairly preserved crypt architecture with focal erosions. The lamina propria shows moderate inflammatory infiltrate composed of lymphocytes, plasma cells, and eosinophils. Few scattered histiocytes are also seen. Diagnosis of specimen A is the ileocecal colon junction, which is lymphoid hyperplasia. The biopsy B of the segmental colon, moderate chronic inflammation.
So what do you do now? ATT for 4 months. There's a stricture in the ileocecal region. And there are few discrete ulcers in the hepatic flexure. Biopsy.
Yes, sir.
Yeah.
Biopsy has not helped you. This is your
Yes, sir.
patient. You have to manage. Tell what you will tell the patient. What are the options available? What symptoms, with what symptoms the patient has come to you?
She's come with vomiting, sir. Predominantly
abdominal
vomiting. With
So what is your
abdominal pain.
what is your diagnosis, clinical diagnosis?
Any you're thinking of any stricture or in view
No,
of the
there is a
weight loss?
stricture. There's a stricture
Obstruction.
there. See, there's a stricture, there's a post-cyanotic dilatation. So you think there's an inflammatory stricture or a fibrotic stricture?
It could be fibrotic, sir.
It looks fibrotic. So
Then
the post-cyanotic dilatation. So what do you do next now?
we may, since we have the mesenteric, we may have to go for a consider laparoscopic diagnostic lab and biopsy for confirmation.
Diagnostic lobe and biopsy from where? Here is patient is symptomatic. Can you treat this as Crohn's? Fecal calprotectin elevated, not responding to tuberculosis, discrete ulcers in hepatic flexure.
It can be treated as Crohn's. Crohn's.
Can we treat as Crohn's?
Yes, sir. But
Do you have enough evidence to say it is Crohn's?
no, sir. Biopsy. There is
Because
no
once
evidence
you
of
decide to treat
granuloma.
as Crohn's, it is a lifelong commitment for that patient.
Lifelong commitment. So what do
It's a
you do?
lifelong commitment. He has to take treatment. As per the current knowledge, the treatment is indefinite. No.
Yes, sir.
So we
But,
don't have a thing of this one. She has been treated for ATT, but she's got a severe, you can see in the CT that there is a very stricture, there's a post-cyanotic dilatation. So even if it's Crohn's, what will you offer her now? Supposing this is Crohn's, what do you offer her?
Stricturoplasty.
Hmm?
Stricturoplasty.
Oh, such a big long stricture, ascending colon is involved. What will you do stricturoplasty?
The stricture is in the region of terminal ileum or ascending colon.
Ascending colon. So the stricture is in the
Okay.
ileocecal region. The stricture, you can see a big post-traumatic dilatation. You'll be able to do how do you do stricturoplasty? How will you do stricturoplasty in this patient? You think the balloon will go in? You saw the picture. Will the balloon go
Yes,
in?
sir. Yes, sir. Yes,
You
sir.
don't
No,
know.
sir. Yes, sir.
What do you think you can do for this? What can you offer for this patient?
What are the other surgery which can be done for this patient?
Uh,
Suppose it was a tuberculosis and the patient presented with this sort of finding, what you would have offered?
To
What you would have offered?
resection with
A surgery, because there's a patient's got
effect
obstruction,
surgery.
not
When you
responding.
have
to
obstruction of the intestine, you have only two, three options. One, as you said, if it is a non-inflammatory stricture, stricturoplasty. But if there is an active inflammation, we can never do that because the anastomosed area will give away and not the cut area will be give away. Second one
Yes,
is
sir.
bypass the obstruction. That is like iliotransverse anastomosis. But generally we
is-
do it when you are sure that there is no Crohn's disease, etc., or there is no other disease elsewhere. The third one is resect the area of involvement, usually right hemicolectomy and iliotransverse anastomosis. This is what we generally do.
This is what we do.
But in
So
this
in this
case,
patient, I
resection
think,
is important because we still do not have a correct diagnosis. So we probably will be able to make a correct diagnosis by deeper sections of the resected specimen. We'll be able to get a better idea of what we are dealing with. And and therefore we can perhaps decide whether she requires further treatment or not.
Yes, sir.
patient actually went back with all the reports and we offered her surgery. And what happened there, somebody saw, and then fecal calprotectin, she was given steroids and the mesocol. But she came back saying she never responded. Okay. After 2 weeks, she's
Yes, sir.
still vomiting and she was not responding.
Is positive fecal calprotectin highly specific for IBD?
IBD.
So once calprotectin is positive in this sort of scenario, are you sure it is diagnostic of
No.
IBD? Yes or no?
No, sir. Not
Why it
diagnostic
is
of-
not diagnostic?
Even in inflammatory conditions, it.
Okay,
fecal
what
calprotectin
does it actually estimate?
it elevates the-
It actually estimate the calprotectin from the shed WBCs, no?
Yes, sir.
Polymorphs. So it only means whatever with the inflammation, it can be positive.
Yes, sir.
Okay, probably we don't have enough studies of calprotectin done on tuberculosis, etc. Most of the studies have been done in IBD, ulcerative colitis, and Crohn's. We don't have. But some authors have said that in tropical countries or in countries where bowel infections are very common, the validity of this may be much less compared to what there in the West, where the hygienic countries where GI infection are less. Okay. But I don't know whether there is any study on tuberculosis and calprotectin. Dr. Venkat, are you aware of anything?
No, no.
I
So
haven't seen any study
she
like that.
was given some course for about 2-3 weeks with steroid. She never improved. Actually, then she was suggested some biological. Then she came back to us. And then the point here is that she's got a very tight stricture with the post-antrum dilatation. That means a fibrotic stricture. The best option is to operate on these patients, even if it's tuberculosis. Or is there an option of ileocecal resection in Crohn's disease?
Yeah.
Do you know anything called the LYRIC trial? Has it shown some benefit by doing a surgery?
No, sir.
Anybody? So even this is a Crohn, if there's a very severe tight stenotic, I think we should always offer her a surgery. So either tuberculosis or, as Dr. Shobna Madam said, this could be a very, very tight stricture because of tuberculosis. And even if you think this is a Crohn's, it shows a very, very tight stricture with a post-stenotic dilatation. Whenever you see a post-stenotic dilatation, it is, and the best remedy is to undergo a resection. So she underwent a segment resection of terminal ileum, cecum, and ascending colon with ileocolonic anastomosis. So this was what was seen. And look at this.
The provisional report came out as necrotizing granulomatous lymphadenitis with abscess suggestive of tuberculosis.
Tuberculosis. So the thing we want to highlight is if the
The abscess means there could have been a micro perforation.
perforation. Because she was also given some steroids.
Yeah.
So,
Yes, sir.
so I think this thing here is if the patient has got a very, very tight ileocecal strictures, either in tuberculosis or in Crohn's, I think we should offer them an early surgery in these patients so that So this, the diagnosis of this has been proven by, because he went to underwent a resection. So here you can see that there was a tight stricture. Patient, in spite of ATT, did not improve because the stricture was very, very tight, and she had obstruction. That's why she didn't improve, even though her, as madam said, fever has settled down and she did not develop vomiting. Second, if this has been a Crohn's also, I think we should offer them a surgery, early surgery in these patients. Whenever there's a tight, for a early, when a stricturous ileocecal disease, and they seem to be doing better after surgery. So now I think with ATT, she should improve, because she's be able to take ATT better, mainly because the obstruction is okay.
Yes, sir.
Madam Jayanti, madam, Shobhana, madam, anything else you want to say?
Yeah, I think surgery would have been the ideal option in this patient, no? It looks more like a one-time surgery.
Yeah.
And it is recommended in patients with this isolated lesion in Crohn's disease and stricturous lesion with tuberculosis, no? The only thing what I could not explain was the vomiting that she had. But if it shows.
Probably very
other thing-
specific. Early
other
into the
thing-
disease, I don't know how that.
Yeah, in Crohn's disease, the other thing is you must ensure that you conserve the small intestine as much as is possible. So there is a role for called as laparoscopy assisted percutaneous enterostomy, that you can do dilatation using the balloon dilators, doing a laparoscopic enterotomy, and then you go down and do that. The other surgical approaches are you do a slit, and then you do the anastomosis in the vertical opposite direction, like a Ramstead procedure. Yes. So in Crohn's, we try to conserve, but if it's an isolated lesion, I think they're justified. And so now in this patient, you think now it's necrotizing granulomatous. So what should we continue the treatment, complete the treatment? What should be the follow-up? Surgery done, completed, biopsy proven, suggestive tuberculosis. What should be done now? Complete the treatment.
Complete the course of ATT.
I think now this recommendation is to put her on 6 months of ATT, because she.
Yeah, because there is active tuberculosis now. So I think we have to give her a complete retreatment.
Retreatment of tuberculosis. So.
Just a quick comment, Dr. LVK. This patient, when you look at the CT scan, there are also multiple lymph nodes. Now that lymph nodes may have
12
already.
millimeter.
Yeah, so 12 lymph nodes, multiple ones. We don't know the CT scan when she started having the ATT. So in such a situation.
No, I didn't have that report. She was told, and then they started ATT, and then she was registered in the government tuberculosis program.
Correct. So that's why what I'm saying is, if there are lymph nodes, our diagnosis should have been more towards tuberculosis with a stricture right at the time of seeing the CT scan, rather than waiting for the surgery. The diagnosis could have been made. Of course, surgery was the best option in this case.
Shobhana ma'am, you might remember giving me the second best paper in India for the colonoscopic evaluation of ileocecal tuberculosis while on ATT. This was
Yes.
years ago. You were the chief editor at that time.
Yes.
Serial colonoscopy while on ATT, and we found around 83% healing by 2 months and near total healing by 6 months. It was DOTS therapy those days.
Yeah. So what about how many people developed resistant strictures in your series?
I don't remember it often, but right now I am writing up a series of the same scenario: ulcer nodular disease of the ileocecal region with no granuloma, but only chronic inflammation. How you proceed further? And we have that series coming up. I think we send it first, that Dr. queries. So I am rewriting it again and sending. So the answer will come out in that.
Okay, wonderful. Should we go for the next case?
You have time, ma'am?
9:20. We may do it in 10-15 minutes.
10-15 minutes.
Okay, sir.
Rajendra.
Quickly,
A 22 years old male with no prior comorbidities in November 2020 developed a fistula with perianal abscess MRI fistulogram showed simple linear intersphincteric fistula noted in the left side with internal opening in 6 o'clock fistulous tract. 6 o'clock fistulous tract is 17 mm, grade 1. In Jan 2021,
He was in 2020, he was given some antibiotics and he responded.
in Jan 2021, developed perianal pain, whitish discharge and swelling, no bowel symptoms. Fistulectomy, incision drainage and rectal biopsy was done. Rectal biopsy was suggestive of non-caseating epithelioid granulomatous abscess with Langerhans giant cells. He was started on category 1 ATT for 6 months from January 26, 2021 to May 24th, 2021. 4 months. In October 2022, perianal pain with white discharge. Colonoscopy showed scattered ophthalmic ulcers in right colon, multiple lineal ulcers with loss of vascularity at rectum with normal ileum. Ileal biopsy showed no cryptitis or crypt abscess. Colonic biopsy showed chronic colitis. Rectum showed non-caseating epithelioid granulomatous proctitis, following which he was treated with antibiotics, steroids, for which he responded temporarily. He presented in February 2023 with complaints of increased perianal pain with passage of blood and mucous discharge since 1 month, along with loss of weight, appetite, fever with chills.
What do you think? What are your differentials at this point? From 2020, it is going on.
Yes, sir.
And he was treated for 4 to 6 months with ATT.
Yes, sir.
So what is it? It is
One is-
straightforward. No?
Fistulizing Crohn's disease, my differential diagnosis. And second, still colonic tuberculosis.
How often you get? How often do you see rectal tuberculosis?
Rectal tuberculosis.
How often you get
associated with
tuberculous
perianal
colitis?
disease.
You take GI tuberculosis. Is it a locoregional disease or is it a diffuse disease? In GI tuberculosis, gastrointestinal tuberculosis.
Loco-regional disease.
Normally local. It will be initially ileocecal
Yes.
and ileum. So very
It's
uncommon.
not that it will never happen, but it is extremely low when compared to Crohn's disease.
Crohn's disease.
Okay, so if you have
Crohn's
perianal
disease.
disease and colonic disease, I think your first, second, and third differential diagnosis should be only Crohn's.
So it has been, fistula has been going on for a long time, not responding to tuberculosis. And he has had 2 fistulas. And once endoscopy was done, colonoscopy was done, the biopsy showed chronic colitis. Okay. Examination was nothing much. Only when you did a rectal examination, ulceration was noted along the outer margin there with discharge and abscess. Now what do you do? What is the investigation like to do on it? Okay, look at these investigations then. Now we think there is a non-healing fistulizing disease. There was colitis. One ileum showed cryptitis. And there was a ATT, but he did not respond to ATT.
So fistula is not responding. So I will start this patient with
Okay,
antibiotics.
interpret this.
You'll start with what?
Antibiotics.
Okay. I know there is a
No,
fistula.
you want
increase.
anything else? Do you want
First, you want to assess the fistula and what the
This is the
type,
patient. How do you
whether
do?
there is an abscess, whether there is a large abscess in the pararectal region, all those things you have to find out. No, so I
Yes,
will
sir.
investigate.
So I will
What imaging
do.
to do?
Yes, sir. MRI pelvis MRI fistulogram.
Oh.
Here he had a high ESR. Yeah. So MRI of the pelvis.
Yes, sir.
So what do you want to look at in MRI of the pelvis in a patient with Crohn's fistula?
Yes, sir. In on the presence of fistulous tract and internal opening.
So you want to look at the fistula tract.
Yes, sir.
Okay. What else you want on the fistula?
And any and
Is it a
internal
single?
opening
Internal opening. Okay. Is it a single fistula or a complex?
complex.
Fistula or a complex fistula? Okay.
Okay, sir.
What more you want to see? You want to see the extent of the fistula?
Yes.
Is it above levator ani or below levator ani? Then you should look for any periapsis or collections. This is what you should look into when you do a fistula. Okay.
Yes, sir.
And there are multiple tracts. They can be inside multiple tracts and everything may be coming down with one. So these are things which you need to look into the MRI of the pelvis whenever you are asking for in assessing the Crohn's disease. And sometimes if you can see the rectum well, you may have to ask the radiologist whether there's enough proctitis or no proctitis.
MRI fistulogram, short segment.
This is MRI.
Yes. Short segment of mild wall thickening and abdominal enhancement in the proximal jejunal loop and rectosigmoid and terminal descending colon showing abdominal enhancement in post-contrast image. Pericolic hypervascularity and fat standing and few prominent mesenteric lymph nodes. So multiple intersphincteric fistulous tract in bilateral perianal region. The tracts are seen coursing predominantly anteriorly and cranially. Intersphincteric collections on right side.
Yeah.
So extrasphincteric collection at 11 o'clock position on right side. The internal opening at 11 o'clock position. Horseshoe shaped fistulous tract in the intersphincteric collection location posteriorly with internal opening at 6 o'clock position and collection adjacent to the horseshoe shaped fistulous tract.
This is the most important thing. So he's got a disease in the rectosigmoid. You could see a disease in the terminal area. He's got bilateral intersphincteric fistula.
Fistulous
Collection.
collection. Yes.
Okay. What do we do next?
Incision and drainage of the collection with antibiotics.
There are two fistulous tracts.
Yes, sir.
Hmm.
One in posterior, one is anterior.
So you do only
collections
drainage or
also.
you do anything else to
collections.
close the fistula?
Yes, sir. One is non-cutting seton.
So you should do first drain the fistula and what drugs you will give?
Either by infliximab. So drain the fistula.
Antibiotics.
Antibiotics. Antibiotics, sir. So
What
either
antibiotics you give? How
ciprofloxacin,
long
either
you can give?
ciprofloxacin or metronidazole.
How long you can? How long recommended to give?
3 months duration, sir.
12 weeks. Okay. So one you can give 12 weeks.
Yes, sir.
You can't start infliximab unless you have drained out the whole.
Drain also.
So you need to drain the fistula and then place a set-on. So I just want to ask you what will be the principles of or treatment of a fistulizing Crohn's. The first one you do.
Fistulizing cross.
You put a seat on, then
Yes, sir.
you start them on antibiotics.
Antibiotics. Yes, sir.
Okay. So you need to then what will you do with the seat on?
Sorry, sir.
Close the fistula with the seat on. You leave him alone, ask him to come after 1 month or what do you do?
No, sir. I will give induction therapy with infliximab once the infection settles.
Unless you have drained the whole thing out well and there's no evidence of infection, you can't give an infection. Most of these patients, when you send for culture, will be heavily infected. So you give antibiotics, you allow most of the drainage to come down. Then you place a seat on and keep tightening the seat on so that the fistula starts closing. But before you tighten the seat on, you should make sure that you have all the collection. There are two collections here. So you need to drain those collections and give them antibiotics. Do you want to do a colonoscopy? Because we still don't have a biopsy proven.
Yes, sir. I will do colonoscopy, full length
I don't
colonoscopy.
know whether we have done a colonoscopy. Just look at the colon.
Yes.
What do you see in colon?
Colonoscopy, multiple ulcers. Ulcers noted in
There are
the.
deep ulcers, some are deep serpiginous ulcers.
Yes, sir.
So the colon. Look at this. What do you see on the left colon? The cecum on the right, the ileocecal region, right colon appear fairly normal. But what do you see?
No. Yes, sir.
How do you describe these ulcers? One here.
Yes,
Is it a Crohn's or does it look like Crohn's or does it look like ulcerative colitis?
linear serpiginous ulcers, most likely Crohn's disease.
Crohn's disease. So this
So,
is bad.
biopsy of terminal ileum showed transmural inflammatory cell infiltration.
Just taking a mucosal biopsy, Rajendra, how can you diagnose transmural disease?
Transmural.
See, that is a
Lamina
theoretical thing for us. For endoscopists, you are only taking mucosal biopsy.
Mucosal biopsy.
So please don't say that.
Yes, sir. A lamina propria infiltrated with densely infiltrated with lymphocytes and plasma cells.
And you have some lymphoid aggregates.
Yes, sir. Microscopic appearance, ileal mucosa with flattening of villi and preserved crypt architecture. The lamina propria showed diffuse lymphoplasmacytic infiltration, the few eosinophilic and occasional lymphoid follicles. Colonic mucosa with preserved crypt architecture, focal cryptitis and crypt abscess are seen. The lamina propria showed dense lymphocytic infiltration, many eosinophils and smooth muscle hyperplasia. Section showed colonic mucosa with fairly preserved crypt architecture and superficial ulceration covered by inflammatory exudates is seen. Focal cryptitis and crypt abscess are seen. The lamina propria showed large lymphoid follicles, many granuloma composed of epithelioid histiocytes, many Langerhans type of Giant cells and few foamy macrophages.
What do you think?
Granulomatous inflammation, most probably Crohn's disease.
So now you just quickly tell us the management principles in this page. He's got crystallizing, he has got colonic and terminal. So crystallizing, you said antibiotics.
Yes, sir.
You said ceton placement, drainage of abscess. And what are the pharmacotherapy you will use in this patient? Can we use steroids in this patient?
Terminal ileum and acidic colon is normal. So
Got fistulizing disease and can we use steroids?
yes, sir. I will give parenteral steroid preparations.
When active fistulizing disease, we don't use steroids. I do agree that still for Crohn's disease, 50% of remission is still brought down by, steroids are used in 50% of cases. But you can't, so once it is all drained, the drugs you can use is, you can't use steroids when it's fistulizing disease. It does not have any effect on fistula. Azathioprine maybe, it doesn't have money. Azathioprine is a good option. Third is,
Infliximab.
you can use biologicals. In biologicals, which is the best to use in fistulizing disease?
Infliximab, sir.
Infliximab.
Adalimumab is cheaper, no?
Adalimumab is cheaper, no?
Why don't you use that?
Most of the
Studies have
literature.
shown that infliximab is still the best drug for
The
the
best
treatment of
treatment for
perianal
fistulizing
Crohn's
Crohn's.
disease. That's it.
Yes, sir.
Okay.
Okay, sir.
Visualizing Crohn's. So probably if this is so he underwent it really took us 2 months for him to really get out of the whole drainage. And now we have started influx. So initially, so just to show the principles of how do you manage a fistulizing disease. Sometimes the fistula can be so up and elevated and above elevated, right? Sometimes you may have to do a diversion colostomy or diversion procedure before this whole thing heals. So here the principles is drainage, ceton, antibiotics. Steroids have no effect. Azathioprine has an effect on that, but it cannot be used as a. Can you use azathioprine as an induction agent in Crohn's disease? What are the induction drugs which can use in Crohn's disease?
One is steroids, oral steroids, and biological agents and JAK inhibitors.
Crohn's disease?
No, sir. Biologicals.
Biological. We don't have still, still tocilizumab is not used.
Yes.
Crohn's disease as it is. Okay, so you should know what are the management principles of fistulizing Crohn's and treat Crohn's disease with fistulizing.
Is there, apart from the drainage, is there any other surgical therapy which was done
Therapy.
earlier?
We can
Suppose
do
your
for
patient is very
fistulizing
poor
Crohn's.
and patient is in a government sector where probably they are not able to afford
No biological.
biologicals, and the patient is having active discharge from the perineum in spite of giving ciprofloxacin and metronidazole for 12 weeks. Is there any surgical option? You have done everything. Antibiotics for 3 months, ceton. Abscess drained completely. Patient has no money for biologicals.
Can you divert it somewhere?
The
Ileostomy.
fecal stream is to be diverted.
What's
By
the
doing-
principle of diversion? What's the principle of
Principle
diversion?
of diversion.
So just read about that, okay? What you need in this particular.
Why do you
patient.
divert actually?
Why do you
What is the
divert?
effect, what is the effect of the fecal stream on a mucosal inflammation? That is the most important thing. So you know diversion, and this is what I think.
Diversion and why do you do it?
So this
Actually,
case
it
was
is different for probably between Crohn's and ulcerative colitis should be different. What is actually diversion colitis, by the way?
Inflammation, like the diversion.
no, what
Yeah.
happened is
What
where do you get diversion colitis?
Diversion colitis. In which scenario?
See, if it's a diversion, you have to divert. So I think the distal segment shows changes of colitis. That is called, once you divert above the distal segment, distal stump will show changes of colitis. Called, please read it up on how do you treat diversion colitis.
That is because the normal mucosa needs a nutrient from the bowel itself.
Fecus.
The short chain fatty acid due to the fermentation of carbohydrate, no? Short chain fatty acid in the form of propionic acid, butyric acid, etc. Okay, that will, the mucosa will be devoured as a nutrition. But in Crohn's disease, probably we don't want the fecal stream to be in touch with these areas, so we want to divert it away.
Okay.
I think it's 9:40.
And you cannot reconnect it, okay? It's very difficult to reconnect. So once it's diversion, it's always just to leave it as diversion. Very difficult to reconnect it once the fistulas heal. I think Dr. A.S. Puri has got article on this. He was the one who was a proponent for diversion ileostomy, okay?
Okay.
Read about the bacteria, read about the microbiota that can still cause problems after your, that's why you divert, because one of the thing is microbiota related problems, okay? Thank you, Enrique. I had
you,
a
ma'am.
nice revision of IBD, yeah.
So this is actually, this was taken, this IOT case, but I think, so this
Very-
case is a sort of, I took some sort of a mini thematic series on surgery in IBD. The first case, we looked at the IBD, how do you do a surveillance and what do you do when you have a malignancy? The second case, if it's been tuberculosis or Crohn's, I think the emphasis is on early surgery to relieve the obstruction. Because if it's tuberculosis, they do well. And even if it's Crohn's, I think early surgery, all of you should read the LYRIC trial. And the third is, how do you manage surgically the Crohn's, fistulizing Crohn's, and what are the drugs you can use for fistulizing Crohn's, and how do you manage subsequently the Crohn's colitis and uveitis along with the fistula. I think.
Thank you, LVK. Nice session. I mean, I
Thank you,
must not
LVK.
say-
It was very good. Yeah.
Yeah, for taking so much of trouble.
This was prepared by my PGs. I think they did a lot of work.
Yeah, we thank them. We thank them
Thank you,
immensely.
PG, please.
Okay.
No, I don't think, but they took a lot of time to do these cases.
Yeah, it's not
Actually,
easy.
the first case who got discharged today, the man who we did a subtotal colectomy. The second case was discharged yesterday, day before yesterday. And the third was just, of course, he's on a review. Right? 2 months back, did a fistulotomy, seton. He was with the surgical gastro, and we just put him only on azathioprine at that point of time after drain. I think he's doing well on infliximab. So this just to have a mini
Yeah,
series
Very
of
nice
surgery and
study.
IBD. Okay, madam, thank you.
Thank you.
Thank you,
Okay.
LVK.
Thank you, madam. Thank you,
Thank you,
Shobha.
LVK,
Nice. you
for
have joined
those
us.
nice cases. Good cases, actually.
Thank you.
Thank you, ma'am. Thank
Okay,
you. Good
so
night.
we have class next on Tuesday, 20th. It's also a clinic on large bowel disease. So I invite all of you to join. Jayanti ma'am and Shobhini ma'am also. It's a case of luminal disease. Again, large bowel disease. Okay.
Thank you, Vicky.
Can we close the session?
Thank you,
Yes.
ma'am. Thank you, sir.
Thank you.
Okay.
Bye.
Good night.
Good night. Good discussion, all the PGs. Yeah.
Are you going to Hyderabad?
Yeah. So that Thursday,
DDW.
Friday I'll be leaving.
Yeah, okay. See you there.
Bye.
Good night.
Good night. Good night, LVK.
Thank you, madam. Thank you.
Thank you.
Thank you.
Good cases. LVK. You should think of writing that clinical handbook in case.
That's what madam was telling me.
discussion in
Yeah.
gastroenterology.
Jayanti madam was telling, I think we should write it.
Yeah. I was telling Jayanti ma'am also. We are discussing so many clinics, so we should actually prepare and minimum 100 cases,
More than that.
100 gastroenterology cases, bedside discussion.
Yes.
We were discussing it with the Jayanti ma'am. She has found out somebody from where, ma'am? Ahmedabad. Her friend is willing to do all the job. I think we should compile it
It's a huge
as early as
task.
possible.
It's not easy. It's a huge task.
So I will keep on pestering you.
We need help.
I will be the pestering person. I will write up some cases from my side. I have also a good collection
No,
of cases.
What
which I
you
have
do,
prepared.
what you do, VT, just put all the cases in the folder and just classify it as esophagus. Just do that bit.
Yeah.
Yeah, whatever cases you've collected, just put it in the various sections, under various sections, and all four of us can do it. Shobna, yourself, myself, and LVK.
Yeah. It will be a collective work.
Sir, just 1 minute. You said about polyp and this thing. There's one more case I'll discuss next time.
Which one?
Yeah. You have it on Tuesday.
Next time, yeah.
Yeah. Okay. That's okay. This is that's fine. That's no problem. All the others will be there. Okay. Okay.
Okay,
Bye-bye.
sir. Thank you.
Good night.
Venkat, it is too late. You have to go home.
Yeah, to drive
You're
back.
still in the hospital. We are all at home.
We'll call you crazy, LVK. Okay, bye.
Okay.
Okay.
Bye. Good night.
Good
I
night.
didn't have time to go back. The traffic will be very high. Then
No excuse, LVK. You're crazy, LVK. Bye. Good night.
Okay, ma'am. Good night.
Good night.